EM board bombs.
Welcome to EM Board Bombs. I'm Marlena Wosiski, and I'm here with our lovely host, Dr. Blake Briggs.
Co-founder and host.
Co-founder and host. You may not know that, but here he is.
Pleasure to be here.
We're going to be talking about a super low stress, normal, everyday occurrence topic.
Just
today.
Another day at the office.
Yeah, so for every 15-minute episode, you get some great learning pearls, and you're going to learn not just for your boards, but also for real life and your actual practice. And that's especially relevant today because you may not get very many questions about this on your boards, but it's something you definitely want to be comfortable with if it ever walks into your ER or is carried.
Oh boy. Foreshadowing.
Yeah.
You know, it's funny, whenever you come on the podcast, we seem to cover, like the audience probably just groans. We're like, oh, something horrible is about to happen. Because the past few episodes, we have talked about when you were on, labor and delivery. Yeah, precipitous delivery. Before that, it was, we talked about adrenal crisis.
Yeah.
Many other issues. So we have really covered the gamut of scary, horrible things that certainly, come into the emergency room. Meanwhile, Dr. Hussein really wants to cover mastitis. Every episode is covering mastitis.
It's right at the top of our script. Upcoming episode idea, mastitis.
Yeah, we'll never cover. I refuse to cover that. Maybe you and I'll talk about that one together. I refuse. We're going to give a shout out to EM News, our only sponsor, Emergency Medicine News, a voice for the people. I'm not sure if that's their name, but it sounds cool. They are the free publication for emergency medicine. All you need to do is email them, ask for a subscription, and it's all free online. You don't even have to ask for a subscription. But if you want a print subscription, nothing more lovely than sitting by a nice fireplace or the beach or on a plane or somewhere else and reading EM News. Check it out. They have great articles. I learn something new every month from them. And of course, we have to give a shout out to EM Rapid Bombs. But we're just going to say it for now. It's called a teaser. We're learning things here from marketing. And then we'll do the stem and we'll tell you more about it afterward. Give our layout.
All right, get ready.
All right. Yeah, exactly. Cool. So let's go dive into the stem here. A couple arrives rushing into the ED with their newborn child. They just finished a home birth and they delivered their neonate like a minute ago. They live right next to the hospital. They said they performed all the necessary safety precautions, including the essential oil diffuser, lavender flavor, the Bose sound system playing Enya, and a salt rock lamp with crystals dotting the room. The father clamped and cut the cord, but noticed that the child, who they named Zeus, was turning blue and not breathing. So in the context of neonatal resuscitation, which of the following interventions is recommended first step in the management of a newborn with inadequate breathing immediately after birth? That was a long run on. Sorry. Choice A, administer IV fluids. Choice B, provide positive pressure ventilation. Choice C, begin chest compressions. Choice D, administer epinephrine.
But before I tell you the answer,
Foreshadowing.
I'm actually going to tell you about EM Rapid Bombs and how awesome it is, especially as someone personally right now who's studying for my board exams.
Please pass them. It'll be awkward if you don't.
Yeah, no, yeah, it really would. No, I've been using it for years. I listen to it every morning when I'm like brushing my teeth and then again at night. And it's just become an easy part of my routine, learning something, refreshing myself. It's just a great way to get that daily, learning without having to sit down and dedicate a lot of time or, a whole moving around, sitting in your study, that kind of situation.
Sure.
You can listen to it in the car, wherever you want. There's 400 something episodes now, almost 500
something. Yeah, it's crazy.
So, you can listen to a different episode every day. It's only a few minutes long, and it really just tells you exactly how the test is going to ask you about certain topics. So if you want a condensed version of this podcast that you can just fit into your daily routine and a ton of other topics that we've never covered on here, you should definitely check it out. You can just go to our regular website, emboardbombs.com, and click on our question bank, and it's right there.
Awesome. Let's dive into this. So We're talking about neonatal recess, just in case you were wondering. This is not a drill. This is not a joke. This is a very difficult topic. This is something that you will hopefully never see in your career, but God forbid you do. We want you to be prepared, and we're covering some key bullet points here of things you need to be aware of. You do not need to be a neonatologist to do the basic, essentially airway skills that are necessary. And no, we're not talking about the intubation procedure part, but the things beforehand, because most of the time you can get away with the steps we're doing beforehand, and you're going to not intubate that child. You're going to do the best you can to do everything to avoid intubation. But sometimes you're going to have to. So let's go into this, because what's interesting here is really the algorithm is what they test on the most. This, neonatal recess algorithm of when you start compressions, when you do positive pressure ventilation, and what to expect on like their pulse ox or like their oxygen level. That is really the core three aspects of this, I think. So anytime a newborn is not breathing properly or has a poor respiratory effort, the answer choice we gave you here was positive pressure ventilation. Now we're going to dive into when that is, though, like when you actually do that and when do you start compression. So Marlena, take it away, and let's everybody strap in. This is going to be a scary topic. We covered the L&D, so now you're back to your worst day ever in the emergency department.
Yeah.
Covering about dealing with the baby now.
So it's exactly what you're hoping won't happen after a precipitous delivery, which is that you now have a neonate that needs resuscitation. But if you think about the NRP algorithm compared to like ACLS or even PALS, like it's so simple.
Mm-hmm.
It may be a stressful topic, but it's a very simple algorithm. So
Cool.
You should be able to get these questions, no problem. And like Dr. Briggs said, in neonatal resuscitation, if the newborn is not breathing adequately, or if it has poor respiratory effort, or if, as we'll get into, it doesn't have adequate pulse, then positive pressure ventilation is the appropriate initial intervention and like the second, third, fourth, fifth, sixth step.
Yes.
This is going to help establish effective breathing and oxygenation before you consider any other interventions. If you think about the fact that the baby has not ever taken a breath before, it makes sense that all of your interventions are really going to be aimed at making it breathe, because that's the big step here. The heart is hopefully healthy, doesn't have any problems with it. That's not what you're worried about, unlike most adults who have a heart that's lived for a few years.
With horrible problems.
Yeah, exactly. This, the heart's not the problem in the baby.
Yeah.
I really hope for your sake. And we're not going to go there. So if you have time to get ready, if you hear this neonate is walking over from its house next door to the ER where it just didn't want to deliver there, steps to prepare. So check that your little like tiny little BVM has the pop-off valve engaged, so that it will release pressure when you get too high, because obviously these tiny little lungs don't take a lot. There's also this like flow inflating bag or anesthesia bag. Where I trained, they called it a Mapleson for some reason. I don't know if that's a brand name, but it's like this like teal colored soft bag. Looks like an empty balloon that should be about half full during ventilation. So you'll have one of those two options. And then definitely preheat the warmer.
Crank it up.
The most important thing. Yep. It's the one time you don't want the ED cold. There's some of these warmers have like a little T-piece on it. If you have that, you can turn on your gas supply, set your flow meter at 10 liters per minute, your blender to 21%, because again, like you're just breathing room air for the babies. They don't need like extra oxygen. Your peak inspiratory pressure is 20 to 25 and your PEEP is 5. So make sure if you have like the little BVM, that you have a PEEP valve on there and that it's set at 5. And that's extra important for these babies because they're just using their surfactant for the first time. You don't want those alveoli to recollapse.
And to people out there who don't have any of this stuff, if they just have a warmer and that's it, then that's okay. You're doing the best
At least
you can.
Turn on the warmer.
Turn on the warmer. And you're in good shape. Okay, why don't you quickly cover umbilical cord clamping? So we talked about this back in L&D, precipitous delivery of a patient. We stopped short of talking about cutting the umbilical cord and clamping. Why don't you quickly just recover that, what we talked about? So you deliver the baby, let's say, or the baby has been delivered. Let's say the baby's still attached to mom.
Right. So the baby's been delivered, still attached to mom, placenta's in mom. So this is a big thing that NRP has made an update to in the past, I don't know, pretty pretty recently
Yeah.
that they want you to delay cord clamping 60 seconds in all eligible infants, so they can get some of that extra blood flow. That's going to be like most term and preterm babies if they look good at birth.
Yeah.
Anyone that looks good at birth, and like even the ones that you're resuscitating, they still want you to delay cord clamping if at all possible. So if the baby is not vigorous but the placental circulation is intact, aka like mom's not bleeding out or the placenta didn't come out with the baby, something like that, then it's reasonable to briefly delay the cord clamping while somebody else clears the airway and stimulates the baby to breathe. If it's still not breathing, clamp and cut the cord so that the baby can be taken to the radiant warmer. Remember, 2 clamps cut in between.
Exactly. And by stimulating the airway, we're talking about the bulb. Using the bulb suction, you're going to use bulb suction on the baby after you deliver them, stimulate, dry. And if no response, then that's when you're going to clamp, take it over to the warmer. Mm-hmm. Good response, good cry. You're going to obviously give to mom and everything's good and you're done.
Yeah.
But if this doesn't happen, to the warmer.
Yep. So,
all right, so what's the first step you're doing here when it comes to evaluating these babies?
As soon as you have the baby, you're doing this like rapid evaluation. It's like almost like your primary survey of the baby to determine if it can stay with mom or if it needs to go straight to the warmer. So you remember this with 3 questions. Does it look like it's term? Does it have decent tone? And is it breathing at all?
I love it. That's good. That's simple.
So when I talk about tone,
TTB.
like remember, TTB. The baby has like been in the uterus, so it's all like clenched up like this. Like it should have tone and it should prefer to have its limbs towards the midline. So if it's like a flop, that's bad.
Starfishing.
Yeah.
I believe the term is called.
Yeah.
The medical term.
If it's starfishing, bad sign.
It's bad. A limp starfish. That's not good.
So what are the 5
flashbacks
initial?
to Finding Nemo.
Oh God.
Today's the day.
Yeah, today's the day you're going to take the baby to the warmer.
So here are the 5 initial steps in newborn care. 1, dry it. We already said all this. Stimulate it. That can be done while drying. Again, aggressive drying. And usually that is rubbing the back and extremities. And usually that stimulates the baby to wake up. And then positioning the head and neck to open the airway. You're also clearing secretions. This is, different how we learned in medical school. You don't need to bulb suction every single baby every single time. Sometimes babies come out and they're ready to cry. They're good to go. Some babies don't. They need a little bit of that bulb suction, and that's totally fine. The ones that can't do it themselves, you're doing. And of course, you're going to wrap them up really fast, providing warmth, or hold them against you, of course. You should already be holding them against you anyway because they are so slippery and they are so prone to going on the floor, which is a bad move, especially if you're doing a precipitous delivery. So make sure you're holding them against you, providing that warmth and providing that stability of holding them. Now, if the baby's less than 32 weeks, don't dry it. The skin isn't normal yet. So it's a preterm baby. First of all, you're having a really, really bad day. You should look into other careers if you are delivering a precipitous delivery with a preterm baby alone. I'm sorry. That would be pretty bad. So if you have that going on, then you don't want to dry aggressively. You want to leave the mucus on as a protection.
So here I'm going to mention that if you're listening to this episode and you're thinking about not freaking out during a neonatal resuscitation, you'd probably benefit from looking at the NRP quick equipment checklist and knowing where those things are in your ED. I did it on my first day at my new job. I went around and did like the PALS and the NRP, like where is everything? Because that's not what you want to be thinking about.
It's like literally less than 1% of people do that.
Yeah, I have a lot of anxiety.
Probably like, who is this person?
I have a lot of anxiety. Like I said, it's a driven behavior. So you just you don't want to assume that everything's on the baby warmer and then find out that they're not at 3 a.m. when it's you and a travel nurse and a sick baby.
Yes, exactly.
Yeah. So the next thing's my favorite part where we talk about actual NRP, or as one of my mentors called it, breathe, 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 breathe. Okay, screw it. Start compressions. Because
that's so funny.
Like I said before, like you're just trying to make them breathe. To be fair, only like 1 to 2 of every 1,000 newborns are expected to require compressions, and positive pressure ventilation really does the trick in the vast, vast majority of times.
Good.
So indications for positive pressure: gasping, apnea.
Pretty obvious.
Heart rate less than 100.
Okay, that is the one. That is the one you're not going to think about. Or at least most of us. We're going to look at that and say, okay, gasping, apnea, sure, whatever. That's totally reasonable. That's the one. Heart rate less than 100. Okay,
it's less than 100. Yep, you got to have the baby's heart rate better than 100 or you're going to breathe. start positive
Yes.
pressure ventilation. A side note that you don't have to wait as long when you're counting an infant's heart rate, obviously, because it's supposed to be a lot faster. So measure the number of beats in 6 seconds and multiply it. You can use a timer or that, like, if you've ever seen neonatal resuscitation, they always do like one person's tapping and the other person's counting. If you have a lot of people around, you can do that. And if you can't hear it, just connect a monitor. That's, put on your pulse ox, and that way you have your preductal sat and your heart rate anyway. And this is because the goal is to start the PPV within 60 seconds after birth. So don't take more than 6 seconds to actually measure it. And again, starting that positive pressure for the low heart rate, less than 100, even if the baby's breathing.
For sure. Sweet. Okay. Once you're delivering breaths, this is oxygen saturation goals that happen. I published, years ago, a social media post on this because it's hard to get these straight about when you would assume their saturation should improve. And so when you're using your oxygen saturation goals for neonates, these are usually almost always written on that baby warmer tower. If they're not, then that is something as a quality improvement project you should do in your ED, because it's an easy fix. Slap on a sticker onto the tower, the baby warmer tower, and you're going to adjust the concentration of oxygen on the blender to that goal, essentially. A normal preductal sat at 1 minute is 60 to 65%. The way I remember this is 1 minute, 60 seconds, it's 60%. So at 60 seconds, you should be at 60%. Easy way to remember that. And even at 5 minutes in, your goal is like 80. Now, you don't have to memorize that number, but just know that this is not going to go to like 100% in like 2 minutes or immediately. When adults, we slap nasal cannula on, you're like, okay, 10 seconds have passed.
Yeah. Yeah.
It should be 100, right? So anyway, remember that the preductal means that that's the right hand or wrist, and you're providing breaths at 40 to 60 per minute. That's really it.
Yeah. In my class, they kept calling this a waltzing rhythm.
It's clever. This class is fun. I kind of want to take it now.
They were great. They were awesome.
Yeah, that sounds awesome.
It's because like in a waltz, you're like 1, 2, 3, 1, 2, 3. And
I like that.
Yeah.
That's very clever. I like that a lot.
Breathe 2, 3, breathe 2, 3. And it very just kind of naturally there.
All right, what's next?
So after 15 seconds of PPV, you assess the heart rate to ensure that it's increasing. So again, everything's happening really fast.
Yes.
If the neonate still isn't breathing, then you begin your ventilation corrective steps. I don't know if everyone remembers Mr. Sopa.
Some people are having nightmares.
I know. I remember hearing that in the class and being like, ugh,
yeah.
Why do I know that?
From the 80s.
Yeah. Mask adjustment, repositioning the head, suction the mouth and nose, open the mouth, pressure increase, which would be like 5 to 10 increments all the way up to 40. And then if you get to the end finally and nothing is working, artificial airway.
Plastic.
Yep.
Sterile plastic.
I think it's all things that we naturally do without having to actually remember an acronym now. But just remember that there's a bunch of steps before you move to an artificial airway if your neonate isn't responding to PPV.
Yeah. Now, if any type of mask for positive pressure ventilation oxygen has been needed for a few minutes, you should also consider placing an OG tube. Remember that these little baby stomachs will fill up very, very quickly. 8 French is usually good. You leave the tube uncapped. You're just venting the stomach. That is it. You're not trying to do anything crazy here. That's something you should definitely think about more than, you're like an adult or something when you're bagging for a long time or anything set up.
You can see it. They develop these little cirrhotic bellies. Really
It'll happen quickly. Very, very quickly. So keep that in mind. It's a good point here. And thankfully, they're usually easier to put in neonates also compared to adults. Yeah, especially adults who have, motorcycle wreck and tons of facial trauma that I had recently. And someone is coming in with an NG, like, nope. Stop. Doesn't end up in the brain. Okay. So you're not going to proceed with compressions or any medications like epi until the newborn has gotten 30 seconds of positive pressure ventilation that moves the chest. So actual, real, substantial positive pressure ventilation, and ideally through an alternate airway. So you could do an LMA, and that works on babies that are average size. And if that doesn't work here, then you're going to move on to your next step, which is what?
If your heart rate responds well, but the oxygenation isn't at goal, so like your heart rate's now above 100, but your O2 sat is still 60 and it's been 5 minutes, you can increase your free flow oxygen using the blender that we talked about earlier that I had Remember, I said to keep it at 21, which is like room. You can increase it to get to your target goal. And if the infant is like breathing well and has a good heart rate, you can give like blow by, free flow via the tail of the self-inflating bag or the mask of the flow inflating bag. Basically everything except an LMA can give you this like free flow. So if you've done all the breathing things that you need, as much as we talked about, and you're not making this progress, so that is if the heart rate is still less than 100 and it's not increasing and you've had 30 seconds of good chest rise, then it's time to go to the A of the Mr. SOPA. You always want to intubate before you start chest compressions in the baby again, because your assumption here is that breathing is the problem.
Yeah.
We're not.
This is all less than a minute still, which is crazy. Like we're like the amount of like decision making that is going on here at this level. Again, it should be automatic, but to you, someone who you as in general, not you, Dr. Siskun, should be a generalized. Okay, I'm a minute in, no changes. Okay, time to intubate. Okay, that's not going to work. We're going to get to the scary part at the end, but these are all things that you are rapidly doing and not thinking hard about. Oh, let's just do this and wait a couple minutes. Right. This is very quick.
Yeah, that's super important. And so if you're delegating roles before they come in and you have a timer, remind your timer, like, I need 15-second interval updates. Yes. This isn't like, okay, tell me when it's been 2 minutes. Yeah. Like, that's too much. So remind them, like, every 15 seconds, tell me it's been 15 seconds so Absolutely. I can make these decisions. We're not going to get into pediatric airway, neonatal airway in this episode, but you can look forward to this, maybe some future date when I just want to scare everyone even more.
That sounds wonderful. Let's do it. I'll see you on October 31st. Yeah.
Yeah, right. Okay, so tell me about chest compressions.
Yeah, so those are indicated when the heart rate's less than 60. Now, this is key, right? Because we think, oh, chest compressions, no heart rate. No. In a neonate, it is a heart rate less than 60, and you can do that via the monitor leads. It will be on the monitor by this time. You're looking at those. And that is despite 30 seconds of positive pressure ventilation with good chest movement. Again, you're doing the positive pressure ventilation. We've been talking about that the whole time. And that is when you're starting chest compressions. If you've done that for 30 seconds, no response, heart rate less than 60, boom. And again, you are giving positive pressure ventilations through your ETT, which you have just placed before you start chest compressions. So positive pressure ventilation, if no change, intubate, then you're starting chest compressions. Now, you will also continue, of course, your positive pressure ventilation through that ETT. Oxygen is going to be at 100%. You're going hardcore at this point, of course. Now, neonatal compressions are interesting. Hopefully, you have done this in some type of like BLS capacity. They at least have like a mannequin where you can practice this, because this is the most different type of compression. You are literally wrapping your fingers around the baby's back and using your thumbs to provide that compression. And you're doing this from the head of the baby, so there's room to get an umbilical line or an IO of some type. You're going to place your thumbs in the center of the sternum, like I just described, just below a line connecting the nipples, not over the ribs. And you're going to place the fingers under the back, and you're going to be doing the saying 1 and 2 and 3 and breathe, and 1 and 2 and 3 and breathe. You're doing, again, this waltzing type of rhythm, waltzing chest compression rhythm. All right, why don't you talk about pulse checks?
So
people are literally sweating. My palms are getting a little.
I know it's anxiety provoking to think about being in this situation, and hopefully mom's not hemorrhaging. So there's also that.
Yeah. Hopefully you called your backup in. Yeah.
when we were doing
Can I get the doc from triage? You're gonna have to pause on the ankle sprains. I need you to come back.
We were doing a
liver placenta
with this during my class, and this poor paramedic that works in this place where it's just him and an EMT basic and a driver a non-medical driver, and they're an hour and a half from any hospital. And so they were trying to actually replicate that. And there was one part where the person playing the driver comes in and goes, yeah, mom was bleeding pretty bad, but we just shoved a bunch of tampons up there. That's what you're supposed to do, right? We just lost it. This poor man.
Yeah. It's crazy to think how spoiled. It's so interesting that people listen to this podcast. Yeah. We have such a wide range of people probably that work in rural environments that are literally nodding their heads thinking, this is what I deal with every day, people. And then you have all these, listeners probably that work, like us, we're spoiled at larger facilities, and we have all these abilities to do things. And we're like, this would never happen. When would I ever have to do this?
Right. Like, where's my neonatal resuscitation team? They're one floor away. They're obviously
exactly.
here by the first pulse check.
Why are they 5 minutes late?
Right.
All right. So finish up your pulse check. We'll wrap it up.
Yeah. So pulse check, let's say your heart rate is now above 60. You can stop compressions, but don't stop your PPV.
Yep. Keep it up.
You can increase your PPV rate back to like the 40 per 60. If you do a pulse check and it is still below 60, then you're going to give epi. So they used to recommend a range of epi. Now, apparently that was too confusing for everyone. So now it's just 0.02 mgs per kg, which is, if you're using code epi, 0.2 mils per kg.
Yes.
So that's the 1 mg per 10 mils. So a little insulin syringe that you should have in
just a little epi.
Yeah. And, that's something to add in your neonatal resuscitation kit. Is an insulin
you do not
syringe.
want to fumble with this. You do not want to fumble with this. And most EDs do not have a, board certified pharmacist that can drop these meds for you. Right. So you are on your own.
Yep. And then a flush after this is going to be 3 mLs.
Not 10.
Yep. 10 is like the full fluid bolus per kilo. So 3 mLs of saline. Protocol. Right. So you're going to repeat that every 3 to 5 minutes that the heart rate is below 60. If you want, you can consider increasing the dose to 0.03, but that's not going to be anything you're going to be asked about on the test.
Yeah.
We're not going to talk about UVC insertion, but a question that I have seen asked is the depth of the UVC. Yeah, the umbilical vein catheter. A question that can easily be asked is the depth of this, which is 2 to 4 centimeters, which is just until you get a free flow of blood. There's one test question answer that was like, do you want to go all the way through the liver circulation? I was like,
oh my God.
Yeah. And in reality, like if you work somewhere that doesn't have a UVC, you can use like a 20 gauge IV catheter. Should be long enough. So that helps you remember that 2 to 4 centimeters is all you need.
Yeah.
And then finally, if there is 20 minutes that you've been doing this resuscitation and there's no detectable heart rate after 20 minutes of recess, there's a really poor prognosis.
So sad.
And that's a reasonable time to consider like framing your cessation of resuscitation efforts.
Yeah. Disappointing. At that point, also, hopefully 20 minutes in, you can at least get some type of help. Hopefully. I know that some people are laughing at me right now when I say that, but at some hospitals with any type of OB coverage, there should be some type of on-call, at least even a community pediatrician that might be able to come in and help you or something, and at least be towards the end to help you make that decision. I know it's a very difficult position you're in if you're alone dealing with that. Why don't you summarize the key steps and we'll wrap this up? It's been a long episode. It's been a scary episode. I think that there's some key digestible points here. I've tried to keep repeating them here throughout our topic about what's your next step and what have you done previously, but why don't you summarize that really fast in less than a minute?
Yeah. Okay. So your key steps here are going to be breathing. So if your neonate comes out and it doesn't have a heart rate over 100, or if it's gasping or apneic, you're going to start positive pressure ventilation. You're going to take the baby to the warmer for this. Initially, you try like the drying, stimulating, suctioning, positioning. If that doesn't work, you start positive pressure ventilation with a mask or self-flow. You do that at room air oxygen, check the preductal sat on the right hand or wrist. You have a little chart there telling you, remember at the first minute, 60 seconds, 60%. And you're doing this like breathing and the waltzing rhythm while you're checking that. No. If you get to a point where the heart rate is above 100 and the infant's breathing, you're good. If the heart rate is below 60, you've had good 30 seconds of positive pressure that's moving the chest, and you're still not above 60. Remember, this is the time you intubate the baby, drop the OG tube, and start compressions. And it's not until the first pulse check after compressions that you will consider giving epinephrine if you're still below 60.
Awesome. And they'll never ask you the dose on the test or oral boards. And in real life, hopefully that decision also is taken away from you. It's already drawn up, ready to go. Hopefully. Mm-hmm. Mm-hmm. All right, cool. That's it. That was awful.
I know.
I'm glad we covered it. It's terrifying, but I'm glad we covered it. So good work.
Yeah. Yep, it's one of those things, I think it's really easy for us to think about like, oh, like I'm going to go through the steps of a crike like on my drive to work today just
Yes.
to re-put it in my mind, but we probably forget about NRP. So
Yes. Cool.
add that into your box of terrors.
Little box of horrors.
Yep.
Yes, and don't worry. Around Halloween, we always come up with some pediatric topic. I think, what was it? Last year was Nightmare on Epi Street, and it was a pediatric sepsis. I thought that was very clever.
That was good.
Yeah, sometimes I got it.
And
We'll
don't
think of a
forget,
clever one for this topic.
we have the airway module if you're feeling anxious about airways now.
We do, and there are pediatric airways on that module. It's free. It's at Ian Bohrbaum's. And speaking of Ian Bohrbaum's, Rapid Bombs, we talked about that. If you want to sign up, it's like 2 clicks to sign up. It's that easy. You can pay with Apple Pay too. If you go to embohrbaums.com, our website, just click on the question bank. It's the only question bank podcast in the entire world for any specialty. So thankfully it's for emergency medicine.
Yeah.
So if you're listening to this podcast, you benefit from the only question bank podcast in the world. It's less than the cost of Netflix per month.
Yeah. I was going to say
awesome.
it's definitely cheaper than anything else you're paying for to study.
Very cheap. We're not going to mention the competitors, but they are expensive and overpriced.
We're blue collar. You remember that. We're here for you.
We respect the working emergency physician. All right, we'll catch you next time. See ya.